Well, welcome to the fourth session of Prevailing Within a Black Swan Event, COVID-19, and these are strategy series for dentists, all dentists. One of the more daunting things that has come up in this very strange, if not shadowy time in world history is how to handle these decisions that are incredibly critical, remarkably daunting, if not dangerous, when it comes to making these business calls. Well, things are in a remarkable state of flux. And in the United States, and there are people listening in that are not within the United States, but within the US, everything keeps changing, and which makes it frightening to make decisions. And this is one of the main reasons that people become quite concerned. So what we put together today are a panel of experts in making business decisions, at least the way things look right now. This is an interesting panel of people, and I'm going to have each of these people introduce themselves and say something about their qualifications. Let's start with Rob Delarosa.
Good morning, Rob Delarosa here. I'm a board certified pediatric dentist and a founding member of a group practice. We now have, I know the exact number, 68 employees, 4 offices, 6 docs currently, 5 pediatric dentists, 1 general, and we're hopefully adding another associate this summer and 1 more next summer. I was past president of the American Academy of Pediatric Dentistry and a long-time nathite, I might mention.
Thank you. Well, all of us who know Rob, and I've known Rob for quite a few years, are impressed with not only his business ability in building a substantial organization which is privately owned by Rob and his partners, but also Rob's ethics are beyond question. Larry Jerrold, another close friend and rather unique individual. Larry, tell us just a bit about yourself, please.
Yeah, hi. I'm a board certified orthodontist, and I'm an attorney, legal editor for the American Journal of Orthodontics. I also have a certificate in bioethics. Was in practice for, 25 years, academia the last 20 years. And currently I'm the chairman of orthodontics and the program director of the orthodontic residency program at NYU Langone Hospital in Brooklyn. I guess we have about 1,000 patients, 8 residents, and that's about it.
So Larry writes for the orthodontists in the group, or those that subscribe to the American Journal of Orthodontics. Everybody, I would imagine, is quite familiar with Larry. He writes the litigation column every month for the American Journal of Orthodontics. Litigation, there's something that strikes deeply in the gastrointestinal tract. Michael Schwartz, please.
Hi, I'm Michael Schwartz. I'm the CEO of Specialty Dental Brands. We're a DSO that focuses exclusively on pediatric offices, orthodontics offices, oral surgery, and we also have a small endodontic group. Got into the industry in 2008, so I've been here for a while. This is the 3rd group I've been the CEO of, and right now we have 25 offices across 5 states in the US.
In the truest sense of transparency, I'm the clinical director of orthodontics for Specialty Dental Brands. I've known Michael for quite a few years, and DSOs, or corporate dentistry in general, seems to have mixed reviews. And there was quite a bit of a mating dance that went on between me and Schwartz as to whether I wanted to be involved with his organization. And it was not until I saw Michael's reaction to some rather stressful situations a number of years ago and how ethically he behaved. What was best for the patients first, and everything else followed. So I'd like all of you to be aware of that as you reflect on Michael's relationship with dental service organizations. And Gay Lowry, please.
Let me unmute myself. I'm sorry.
I know the feeling.
Well, after a very long background in medicine and nursing, I fell in with a bad group of orthodontists in 2005 and joined the ortho world as a manager and executive director for a large privately owned orthodontic practice. Ultimately, we sold with 23 locations and had over 100 employees and doctors. And I do consulting now. I come into practices and evaluate practices. I do a lot of coaching managers as well.
Another individual who I had personal contact with and have observed how she behaves, and I'm sure as many of you feel, well, let's just say as a tribal elder or gray owl and gray matters. I've spent a long time within dentistry and within the subspecialties of general dentistry, pediatric dentistry, and orthodontics. And I assure you that at this point in my career, I will do nothing to soil the end of my reputation. That's just not going to happen. Everybody involved in these presentations is an individual of substance with ethics. It is, money is the reward. It is not the driving factor. Now, the chat function should be open. Isn't that right, Phil? So the chat function is open and you are welcome to chat in questions. Our next presentation will be this Thursday, where we're going to deal with various factors in how to decide about opening an office, despite what the government or your state governments are saying what might be best for that. So if you want to chat in those questions, I know that everyone is quite interested in individually what Martha Ann Keels is doing, and what Bobby Elliott is doing, and what Phil Slonkosky is doing, what Delarosa is doing. And those things will be discussed in detail this Thursday. But again, you're welcome to chat in the questions. One of the more provocative questions is that all of us have is, well, what is Martha Ann Keels doing? Because Martha Ann has a PhD in epidemiology and also is very closely affiliated in a few different ways with Duke University. And she's going to be covering some of those things in detail and in more detail on Thursday. The first question we're going to address, and then what you'll notice is that the people online will raise their finger when they have something to say. So we don't want to talk over each other, since that tends to ruin the audio. Within, let's say, 36 hours of the finish of this, the recording will be available. You will receive a link to the recording if you're an IPEDO. If you're on my Nathos mailing list, you will automatically receive notification of the link on YouTube. And as a courtesy to the specialty, you're aware that there is no charge for this. I think one of the first questions we're going to address is how should concerns of team members be addressed who are afraid or refuse to return to work? This seems to be kind of a common question, is what should be done about that? Now, we are going to stay away from trying to interpret what the different loan situations are through the US government. We're going to stay away from that because it seems that those things keep changing and we are not in a position to discuss that. Gay, what would be your comment about this? And again, the question is addressing concerns of team members who are either fearful or refuse to return to work once the opening date is decided by the individual office. Gay?
Well, it depends largely on what your decision was when you closed, whether those employees were laid off or they were furloughed. because your relationship is different. If you've laid off an employee, that means their employment was terminated. They were removed from payroll, so you're rehiring people. So you might handle those a bit differently and onboard those just like you would a brand new employee. If you furlough those employees, which most people have done, they continue to be employees. They're just employees that are not getting paid for the period of time of that furlough. During that period of furlough time, those people can actually continue to work periodically as is needed. Those are the folks that are coming in for emergencies, that may be answering phones, doing your billing, that sort of thing. In most cases, of the docs that I have talked with are not bringing their full team back on immediately because of the anticipated patient volume. I have many practices that are coming in and they're going to work 10 or 12-hour days, and they're going to split shifts in order to accommodate the patients. But bring them back slowly, make sure that they understand what the expectations are, and be clear about your retraining. I'm sure that Martha Ann will agree with that. We've got to make sure that we're absolutely clear about the retraining from the front desk all the way through to discharge.
Rob?
Well, I think you have to look at it on the short term and then on the long term once we're much more back to normal. But the reality of the situation is if you've done all the training, and in that training and education, it's to let the staff people know everything we're doing to keep them safe. All of the protocols that you've done, the average of $11 to $35 of personal protective equipment that you're now enhancing your procedures with. If you've done all the education and you've tried to clear up the question, what specifically is bothering you about coming back? How do we address that for you? And then ultimately that decision becomes theirs in the sense that, understand that we're doing everything we possibly can to bring everybody back. We furloughed all of our employees, and we've kept some on that were key personnel. But I really feel like if you've educated them, you're using the science, you're following what the guidelines are from CDC, ADA, AAPD, and everything else, that's the best that you can do. And if you have someone that decides that they can't be comfortable in the environment, that's going to be a problem.
Well, I think that one of the more interesting questions that I've seen racing across my emails are, what about people who say, well, I don't want to come back because I'm making more money being unemployed? Now, my personal take on that is that person has self-identified as a non-team player. And I would be thinking, really? Well, maybe then you're never coming back. Now, my friend Gay Lowry has often referred to me as the executioner when it comes to these types of things. I'm not really into rehab beyond a point, but I think Rob's point is exceptionally well taken, is ask specifically, what are your concerns? And I want to underscore that which we've mentioned in all of our other 3 conferences: safety first, safety always. Michael Schwartz, what would be your input? And our question, by the way, for those of you that are just joining us, is how should the concerns of team members be addressed who are either fearful of coming back to the office or refuse to do so? Michael.
So I agree with both Rob and Gay. I think we know that patient volume is going to be down at the beginning. So what I've been recommending to our partner doctors is we're controlling the capacity of our office. When you think about an office reopening, you have patient demand and you have your capacity. And as the providers, we're kind of turning down the spigot of the funnel to control that capacity based on social distancing and extra time to clean and disinfect. So bring back the team members for that level of patience, which then allows you to have a backup team if something happens going forward. If there happens to be somebody on the team gets sick, you have kind of your backup team that you can swap in. I think it's a good time to, you know, if you haven't been doing performance reviews mentally, to kind of rank your people in each of their positions. So obviously you want to reach out and bring back your A players, your best dental assistant, your best front desk person, or whatever it is. And slowly you're phasing your team back in just as you're phasing the patients back in. And I think if you do that in a way, you're going to have some people that are afraid to come in and kind of move down that list. But I think everything you said, find out what the fear is a big thing that you could address. And maybe not everybody makes it back. I mean, you know, if the patient volume's not there, you might not need the same exact numbers of staff that you had before.
What's interesting in being involved in the corporate world with Michael Schwartz, I don't know that we have ever looked at the potential of acquiring a business, a pediatric dental or orthodontic business, because that's our niche, pediatric dentistry and orthodontics. I don't know that we've ever looked at one where we didn't find the following asterisk: employees who are underworked and overpaid. And the boss usually says, yeah, but they've been loyal, they've been with me for so long. But now these people have developed, certain individuals have developed basically an entitlement attitude that you wouldn't be who you are without me. Well, again, I am trying to soften up my executioner's axe. But if these people have identified themselves as those types, this may be your time to gather your courage and decide whether you really want them back. Larry Jerrold, from a legal standpoint, your comments, please.
I was just listening and I was thinking, depending on how you're splitting shifts, depending on what your workload is going to be for your staff, one of the things you're going to have to take into consideration is going to vary state by state, are going to be some of your wage and hour laws and how long people are working in shifts, and whether you're extending your total hours over the week past a certain number. I think that's something you're going to have to pay a little bit of attention to. You know, you're always going to have people who are going to claim that the work environment is not safe. I think you're going to have to deal with that in terms of spelling it out, how you're basically making that an appropriate environment for them to come into work. I know that one of the issues we're having is some of our employees, because schools are still out, don't have childcare coverage. And so it makes it very difficult for them to come back into the office. Not that they don't want to, they just really can't. And so I don't know what the solution to that is going to be. But you're going to have to treat situations like that a little bit differently than the person who just doesn't want to come back because of whatever concerns. So those are the only things that pop into my mind right now.
From a compassion as well as a creative standpoint, I am quite aware of measures that over the years Bobby Elliott has taken, given, let's say, an extenuating circumstance of lack of childcare or a responsibility to family members that the person really does want to come back, but in fact can't. Bobby, do you have some thoughts for us on that, please?
We tried to identify this when we were designing our office space, and actually made a little TV area. If there is a team member who wants to bring their child to work, perhaps in the original design, if their child was sick and wanted to come in and be able to eat, watch TV, and the parent who may be living check to check needed to not lose hours, they could physically bring their child to the office. So we're offering that if parents or team members who have young children, school-age kids, want to bring them to the office, we have space for them.
Anybody else wanted to comment on that from the panelists? Right. Remember that you can chat in your questions, and this coming Thursday at noon, It'll be a bit of a town hall discussion, and we will address whichever chat questions come through, especially those that seem to be more popular. One of the things that I want to address, the next thing I want to address next is Rob Delarosa. And Rob is, I guess my personal thing is, I'm a big believer in chaos theory. And any of my friends who, if I know you see this white thing behind me, but if you saw what was around the white thing, it looks like something, that's the maid. If the, it's just chaos. And, you know, I'm the quintessential guy of organizing things by the aged stack method. If I'm looking for something, let's see, when's the last time I saw it in the stack? Right about there. But Rob is an expert in systems, and he's really quite sophisticated. One of the points that he made when we were discussing our points for discussion, his number one point was this: if you as an individual, as a business owner, have not done a deep dive on the data and metrics of your systems of your operation, it is urgent that you do so immediately. Rob, would you give us some more information about that, please?
Well, there's actually two sides to that statement. The first side is you need to know where you were, because if you don't know where you were in times like this, it's very difficult to understand where you're going to be. We had a discussion among another group that I'm involved with where somebody was talking about, they were bringing an associate on and said, well, how much should I pay? Should I pay 25%? Should I do that? And I'm like, you know, you need to know your number. To the best guesstimate that we have now, we need to know what our new numbers are. And I'm talking about really getting down into the weeds on it, because we did an analysis of, based upon what we could purchase now. And boy, we just went on a stock supply scavenger hunt and found things like, we've got KN95 masks that we picked up for $3.83. We've got gowns for 98 cents. We figured the cost of double gloving at 28 cents. So when you start piling all this on, like I said, it was the best plan with what we could get on the less expensive end was $11. On the higher end, it's $35 to see the patient more than what it was. So knowing that, we've instituted, you know, a COVID PPE fee that we're charging, and we set it at $25, which was right in the middle. And with the emergency patients we've seen, and now in Louisiana, we can do some time-sensitive patients, which we started. I mean, I saw 4 patients yesterday. Each one of the partners has taken a day. Well, you know, we've had no blowback on that, you know. So what I'm saying is, I think if you understand that you're running a business, and how are you going to bring back all these people that you have, it is going to be a gradual thing. And you are going to have situations like Larry said, where somebody's got, you know, daycare issues, or somebody has this, or somebody has that. I think it's critical that we know after the PPP 2.5-month gift or grant, if you want to call it's been given to us, we need to find out what we can afford, what we can't afford.
Go ahead, Larry.
So I'm assuming that for your orthodontic patients, they've signed a contract, as most every other orthodontic patient does. How are you tacking on this additional $25 per visit charge when they basically probably signed a truth in lending statement for whatever the monthly charge was going to be?
Well, in our practice, Larry, what we have seen so far was really pediatric dental emergencies. I can't think of any orthodontic emergency that we've seen. So that is a very good question. You know, I think if we do that, you know, there's going to be a contract amount. Well, and that brings up an excellent point. And I know we're like other people that I've spoken to, even though the governor says you can open up, some people are wisely choosing, well, I'm not going to do it just this week, but boy, we're going to strategize how we do it. Because one of the things we stress with our team is that, look, we don't want to go get ahead of ourselves and then have to retract or go back. And that's why, you know, this thing with the PPE stuff, in my opinion, for the now, why do it when you can overdo it? I mean, we're doing skull caps, we're doing face shields, we're doing KN95s and a surgical mask on top, we're doing gowns, double gloving. We're going that length because suppose that is what the new normal is. I need to know how to put that into the process.
Well, keep in mind that, yeah, I know this is a absolutely, it's a burning question, is what should be done in order to follow what personal protection for everybody is supposed to look like. And those rules are going to be in flux. There's really nothing exact that you can count on at this point. So one of the things that's come up, again, I want to remind you that Thursday, we're really going to take a hard line look at this. But I know that Martha Ann has been cautioning people to not spend a bunch of money on things that either are unnecessary once the government gives us what these guidelines are, or either over or underkill. Martha Ann, do you want to make a brief comment about that, realizing that we'll hit it harder on this Thursday?
Yeah, I mean, I totally agree with that, to hold out on things like negative pressure rooms. I do think, you know, something that does make sense, which going forward, you know, if you were to buy a new air handler today, it's going to have technology, either UV light or I-wave technology in it to really help purify your air for the building space or your home. And I think that is a smart move, to look at what your air handlers and are they going, what process that air is going through in terms of circulating through your office. But that's something maybe we should have done anyway. But I've been doing this like Rob for over 30 years, that, you know, just revisiting that, I think that's some common sense things. But I think I'm doing exactly what Rob is doing, and following that. Now at Duke, we're not double gloving. I mean, I don't see any harm in it, but we're not doing that. And then the scrub caps, unless you're in the OR, are optional, even if you're on the front line. So I think we'll vary a little bit on the culture of with which we live in, and what my patients are going to, you know, those that are seeing the news and seeing the front line and at Duke and UNC, they're seeing what they're wearing and what they look like and what they're doing. So we kind of need to sort of think about that as well. But I'd caution, I mean, if you're in a negative pressure room, the minute you walk out, you're in a positive pressure room. And so you can't create a negative pressure room for the entire experience unless you're going to negative pressure your entire building. I mean, it makes sense if you're going through a stem cell transplant and you're going to be in a room for 3 months and you want to make sure this, you know, that your exposure to any particles is minimized. That makes sense. I'm not sure it's going to make sense in the long haul for practicing dentistry. I always give myself some wiggle room for everything. That I don't think that makes sense, but I need more science for that to make sense.
Michael, you had something? Rob, you'll be next.
I wanted to go back to Rob's point about knowing the data. And I think that's, as you look at businesses across every industry, you hear things like big data, you see the commercials with IBM Watson. Dentistry traditionally has lagged behind, being at the forefront in technology and in business practices. A lot of us say, you know, it lags 10 to 15 years behind medicine. I still think there's a ton of pediatric dentists out there developing film x-rays. You know, it's not 100% digital x-rays out there. But going to the data, I think the exercise Rob's done in his group is something that everybody should look at, is how much does it cost you to see a patient? What is your break even? Because this is going to be the first time in a lot of years that you're not just open for a day and trying to book your schedule to the maximum schedule. So you're putting that constraint in. So you need to understand if based on the guidelines and the social distancing and the layout of your office, if you can only see 10 patients a day and you have to have X amount of staff and X amount of PPE, are you going to lose money? And maybe that decision says, well, maybe I'll wait a week to open until we have more ideas, or maybe my break even's 15 patients. So one of the exercises our group went through was what is our break even? We know, and I think most of you probably know in your own office, what's your production per appointment? What's that average? In pediatric dentistry, and I've been in it a long time, depends on your insurance mix and your Medicaid mix. I've seen it as low as $120 a patient. I've seen it as high as $200 and change. But if you know that, and you know you're putting a physical constraint in your office that you can only see X amount of patients, you can figure out that the approximate revenue you would have that day. And you need to know what's the break even for just opening your office, fixed cost, and then add on the staff and what that variable cost goes to. And that can help you make a decision of, yes, my governor says I can open, but am I going to open and just lose more money? And I think that's what's going on in the restaurant industry right now. I know a lot of people that own restaurants, if they can only open at 50% capacity, they're already running such thin margins that it's not worth them to open. It's going to accelerate their problem. So really understanding your numbers, I think it's great that Rob said that, and he's doing that, and he has a group, but it's private practice. That's something that everybody should adopt and get more into the analytics of their office and understand that.
One of the things that I want to mention, and I think Rob has something to contribute on this specific point, but what we've gone through, and I mentioned this during our very first conference, what has happened is we have been enjoying the best of times for a long time. I graduated from orthodontics 38 years ago. I graduated from pediatric dentistry 41 years ago. And every year has been better. It's been that way.
Roger, wants to know where you're going to be.
Put your hands in your lap. We've been going through these great times for so long, and wham, we hit the wall. And that is what I mentioned this in our very first conference. Again, I want to repeat that times have been really fat and happy, seriously fat and happy, to the point where lots and lots of business owners have not paid attention to what their running costs really are, because they were walking out with plenty of money. Their kids are going to private schools. They got the boat, they got the pop, they got the fancy resort. Well, that is over. And anybody who thinks we're just going to bounce back like some sort of flubber ball, that's just not going to happen. From talking to very, very high business level people, and through an introduction again from Michael Schwartz, I met a fellow who used to be the head of REI International, the sports people. He brought it to where it is now. He's no longer the head of it, but he was at that time. His comment about being successful and thriving, forget treading water, thriving, is you better understand two things if you're going to make it, or you will go away. You'll vaporize yourself. The two critical things are: understand you are running a business. And if you don't know how to run a business, you better hire people that do. They can analyze what Rob is saying. The second thing is consistent customer service. If as an individual business or a corporate business, you can't do those two things, you're just not going to make it, especially now that these fantastic times of fly high are over. Rob, you had something.
I did, Jerry. I just want to go back to the comments about the PPE stuff. The discussion to put that $25 fee on there was a difficult one, because these are emotional times and people are real tight for money. And therefore, the visual display of double gloving and putting everything on is beneficial for your staff and the patient's parents and the parents that you see. Because I can tell you, yesterday I was in my office, and to put it all on properly and then to de-glove, say, okay, let's go over this. First set of, the first glove comes off, and this is how we follow this. This is how we do that. That visual is worth $25, because I want these families to see what our group is doing to protect everybody. And the other key to this is I know in my case, a lot of our staff members, they're not any more educated than mom and dad who aren't in the industry to some degree. They see it every day, and there's hopefully some education by osmosis. But I want them to be really comfortable that I've put them on our front line, giving everything we needed to do to make sure they're safe. And to me, I learned visually, and to see 2 sets of gloves on, popping that first set off, then taking the gown off, then taking this off, keeping that 95 mask on. I tell you, I think that's, for the now, the new reality, at least from my practice.
Yeah, I think that's a perception is reality, and the entire team needs to be on board with it. Larry Jerrold.
Yeah, I just, I guess, you know, our comments, our knowledge is based on our experiences. And when I was in private practice, I was a large third-party participating provider. Now I'm basically in the public health sector at a federally qualified health center. And, you know, I'm thinking about this not so much in the short term, but the long term. And so if we look at what's going to be down the road with what Rob and what Michael were talking about, and we know that there are going to be significant, we haven't defined significant yet, but significant increased costs to our overhead. Now all of a sudden you have to decide, okay, so how am I going to make that up somehow? If many of us who are listening to this are thinking, well, we'll just increase our fees. And then once you start doing that, then all of a sudden you start impacting access to care issues for a huge number of patients out there. And so I think that down the road, we may have to take a much more broader look at this in terms of maybe there are different ways to do what we're doing that can offset these increased expenses rather than doing it the same old way. I think there's several different ways we can try and balance the books here.
One of the, I hope that all of you have your chat function open, everybody that's watching this video conference. This might be something that's a bit of a look at Thursday, but I think it's something that should be addressed. Stefan Reinhardt from Montreal, Quebec. What is the impact short-term and long-term if other people are open and you're not? Now, that's a very provocative question. And Michael, what would be your comment about that?
So I've been saying my go-to line is nobody gets a trophy for being the first one open. I think like a lot of people on this webinar, our offices have been open for emergencies only. I think there's a lot of people that are itching to get reopened. I think a lot of the things people said so far today are important. You can't open if you don't have the PPE. I've been taking a tact of I'd like to wait 2 weeks after other practices start reopening, just to see what's going on out there. You know, we've done patient surveys that say on the pediatric side, a lot of our areas, we're in Georgia, Tennessee, Texas, Wyoming, and Montana. On the pediatric side, a lot of people, you know, it doesn't go to a majority wanting to come in or being highly likely to come in until June. So I just think, I don't think there's a trophy for being the first one open. I think you have to see what happens. Is there going to be a spike in your area? And I just think you got to check all the boxes for making sure you have all the PPE, you've got your systems down. We're going through a whole retraining. We've put together a COVID-19 training manual. The day before we reopen any offices, we're going to put the entire team through training. So I would just be careful. I think you do have to balance. Look, a lot of us in here do rely some portion of our business on referrals. So if the market starts opening in your area and you go a month, 2 months and you're not open, you do have a chance, you know, you might lose business. So it's a delicate balance. I don't think you're going to be punished from your patient base if you wait 2 weeks, even 3 weeks. If you wait 2 months and everybody's reopened, then it is a risk. So we're kind of using that 2 to 3 week as we'll open after that, and then slowly phase in the patient re-entry into our practices.
I think the image has got to be safety first, safety always. And that goes for the whole team. And the team needs to buy into this 100%. Martha Ann.
I'm thinking sort of like Rob, that we have to grow a culture of potentially adding a facility fee. And that's sort of the language that's used in the medical side of healthcare. And to continue to encourage the ADA to educate the dental insurance companies that, I mean, essentially it's a facility fee, that it's all this extra PPE that we're having to provide to make the facility safe. So I think that culture already exists in healthcare, the medical side, that we should maybe take it more seriously, I think, on the dental side.
Gay, did you have something on that topic?
Yes, I think that it's really important to make sure that we stay in touch with our patients and encourage them and give them a heads up. And as to what Martha Ann said, people will understand. Those loyal patients will understand that there's got to be an additional charge for the additional services that we're providing, for the more intense protection that we're providing to them. But stay in touch with them, in communicating with them in advance. Use Facebook and all social media, and let patients know what the new world may look like to them, in a fun and encouraging way. Some of your practices have done some incredible videos during this period of time when offices were closed, to stay in touch with your patients. So doing that and finding a way in that fun education, staying in touch with your patients, let them know that that this new world will be a little different, without doing it in a fearful way, doing it in a fun manner. Some patients will be angry that there's a charge, but the reality is we can't afford not to do that.
Well, bear in mind that post the U.S. tragedy of the attack of September 11th, there are quite a few areas that charged a September 11th security fee. And I would throw a suggestion out there that if you're going to add something on, I would call it a COVID-19 safety fee or something like that. I mean, to just blend it in and not tell people, I suppose, is an option. Bobby, did you have something on these lines?
No, I think I follow what everybody else is saying, that if it's going to take more for us to provide the safety and the care that we're so used to doing, there has to be a way to recoup that cost. So I agree.
Well, or you're not running a business. Larry, something?
You're not running a business. Number one rule, run a business.
Okay, one of the things I did want to address in this particular seminar has to do with selling your practice. And I have received nothing short of, I'll bet 50, I think that's a gross understatement, emails from people saying, well, I've been thinking about my exit strategy. I was trying to delay it for a few years, but now with the new reality of whatever is going to descend on us for safety reasons as dictated by government standards, I am more seriously considering my exit strategy. And Michael, I know that was the first point you mentioned in your bullet points, is the pool of buyers. Could you give us some comment on that?
Yes. So just one last thing on the facility fee. I totally agree with that. I think it's going to take the ADA lobbying. I know there's a lot of questions going on in the chat. It's my understanding you can't charge that to Medicaid patients. So, and in pediatric dentistry, we know there's a lot of kids on Medicaid, but I think for private insurance, you could charge it if the insurance doesn't pay for it. ADA came out in their workbook and said, charge it, here's the code to use. I don't know any insurance companies that are gonna accept that right now unless they get a lot of pressure, but for Medicaid, you can't do it. So, all right, going to transitioning your practice, I think, Gerry's mentioned a bunch of times, we've been on this incredible growth curve in dentistry. My experience over the last 12 years has been not a ton of doctors, especially the doctors in the top 50% of providers out there, have had many down years. And even in the recession of 07, 08, 09 area, there's a little bit of down, but a lot of the successful practices maybe were flat, and there's been this great growth. And I think now we've had a complete, unprecedented event, and a lot of doctors that were waiting and said, okay, I'll wait a couple more years and then I'll do it. I think those are the ones that are probably reaching out to Gerry, and we're getting a lot of calls also. I think the pool of buyers is definitely changed. It's been changing for a while. Right now, there's probably 90 to 100 DSOs in the US market that have some, more than, let's call it 5 or 10 locations. That pool of buyers is continuing to grow. So that's a good thing, especially for the top providers, private practice providers, because I've always said the more successful you get in private practice, you've now shrunk your potential buyer pool, because a lot of that old dentist to dentist transition, you've become so successful that no younger dentist can afford to buy you. So as you get bigger, and this even happens, it could be a solo practice doing $2 million. There's not a lot of residents that can come out and buy that like in the old days. So I think the pool of buyers, the DSOs will still be there. I think your private practice pool of buyers is shrinking because they've been affected by this. But there's still abilities to transition. I think the big thing to think about right now, if you're looking at transitioning in the next 12 months, is we were getting near the peak of valuations over the last, I would say, 12 to 24 months. So you've probably heard from friends on great deals they got. Valuations will probably start to come down a little bit just because of everything going on in the market. Deal structures will change also. So there'll probably be a little bit less money up front and a little bit more money put into a mechanism of an earnout or a deferred payment. And I think when you talk to, if you're somebody out there thinking about transitioning your practice in the next 12 months, you need to look at, there's going to be a pool of buyers that says, we're going to wait, you were shut down for 2 months. We're going to wait and make sure that comes back. So we want to talk to you, but we're not going to give you an offer or anything for 6 months, 8 months, whatever. There's going to be another pool of buyers that say, okay, you had a great practice before this. There's nothing that tells us that you're not going to come back. So we're willing to do a deal sooner, but we're going to put a little bit more of the deal value into this earnout. So when you do come back and it proves itself out, you'll get some of that money at that point in the future. So I don't think there's any doom and gloom here. I think for those of you looking to transition your practice in the short term, there's still plenty of buyers for you. But I do think just overall in the dental industry, groups are becoming the predominant buyers, and that doctor to doctor transitions continue to shrink every year due to all the things we know about student debt and things like that.
Now, one of the things that that seems to be zipping around is that, for example, the reality is that orthodontists are having problems finding jobs. The universities can deny that all they want, but if you look at the corporate people in general, I think Michael will probably nod his head that hiring an orthodontist to work is not very difficult. Right. Hiring a pediatric dentist, however, that has been very, very difficult. Well, what the speculation is now with this new reality that people think of your own practice. Well, you were going to bring in an associate and you were going to bring them in full time. Well, Rob, would you make a comment about that, about the idea of that I'm mentioning, about that concept about the workload?
Yeah, no, I think that's spot on. In fact, we're engaged in those conversations both with our current associates. We had one, I guess, fortunate thing that happened. One of our associates was starting her maternity leave on like March 20th or whatever, so she was going to be out of the mix no matter what happened with us. And even the one that we're engaging with to bring on in July, I've been in conversation with her and saying, look, I don't know what the picture looks like yet. It is our intent to bring you on in July, but I will be talking to you as we learn more and see how we open up. I will say this though, I think if we're innovative and adaptive, I think we can come out of this pretty good. Do I think the day of the, wide open, wild, wild west like it's been in pediatric dentistry heretofore and before? Yeah, I don't see that. I think you're going to have to maybe change your treatment mix or learn something new that's your niche or whatever it is. I think we're smart enough to adapt and be flexible and then be real with the numbers. Because look, the worst thing you can do is tell somebody, yeah, come on, and then 3 months later say, yeah, I miscalculated. I didn't realize I was losing money on you. You got to be able to let them know. And like I told this colleague in the other group that I was in, for a young associate, this is an eye-opening experience, this conversation, because business ain't cheap. And when you're involved in what we're involved with, it's extremely expensive and maybe it looks different.
Gay, did you have something to add on that particular topic? Oh, you have to unmute.
Oh, sorry.
Yeah.
I thought you could read my lips. I apologize. No, I think to the point is, again, what everyone's said, it's going to take time. When it comes to selling practices, everybody over the last 4 or 5 years has had an unrealistic idea of what their practice value is, and some of them will have a hard time understanding that that the practice value has decreased with this, and practice centers are going to struggle with this new norm of re-educating their employees and their patients. The people that take the time to listen to these webinars are the people who are going to be proactive and move forward. The practices that I'm concerned about are the ones that are not staying on top of the news the way the listeners of these webinars are.
Well, certainly I would hope, and I agree that we have selection bias because people listening to this or actually watching the recording later, these should be the people that are thinking, all right, this is a new reality. Delarosa is saying you've got to know your number. I never did, for real. A lot of you know I ran an orthodontic practice for 38 years with 2 employees, 2, 1 assistant, 1 receptionist. That was it. Well, I never had an employee problem, but that's not realistic. So if you don't know these numbers that are essential, you really do need to find those out. And if you're not capable of doing it, and I would not have been capable of doing it, I would have hired Gay Lowry. That's what I would have done. Michael, did you have another comment?
I just want to say something about the associates. I think there is an opportunity, depending on the size of your practice. As a group, we're in kind of constant recruiting mode, right? And the challenge is, based on the cycle of residents graduating, trying to line up that timing doesn't always work. You need somebody in December, but everybody's in school still. But what I've noticed over the last 2 months is there's a lot of residents that I think probably had offers with private practices, and those offers have been rescinded. Not everybody's, probably been able to do what Rob's able to do as a group, where, can keep that communication, might have, has multiple doctor practice. We've seen probably the most increase in my last 5 years working with pediatric residents, the amount of people available out there. We, for instance, just signed a deal with somebody that's graduating, in June. Also that kind of timing from first conversation to actually getting to an employment agreement was the shortest that I've experienced in my last 12 years. So I think the residents are seeing, there wasn't that guarantee that because there were so few of them, they could get any job they wanted. I think they're being much more proactive this year because of what has happened. So for those of you out there that were thinking about hiring a resident that still have, multiple doctor practice, I think you can really get some good people, because those people that normally would have signed early on in second year are available now. So there is, there always are silver linings, even when it is, a crisis like this. And I think there's some good talented doctors out there for those of you that have that capacity in your offices to look at people.
Phil, you've been conspicuously silent this time around. Any comments, questions, concerns?
I'm just going to echo the numbers. I'm a numbers guy. I think if there's one takeaway that I think this whole crisis hopefully will do for our profession is force people to understand their numbers. The DSO market emerging into the space has required us to be more efficient. And there's nothing like increasing your overhead costs, the percentage that we're going to have to do to meet this. That, the practices that will survive and thrive are going to be those that understand their numbers. And that's going to be the key moving forward. So, yes, there's different regulations we're going to have to take up to, but I think my concluding thought for this seminar is understand your numbers. Take the time this next week to really understand your break-even point, know what you need to make, because if you know that number, all the rest of the stress literally goes away. You're going to know how many people you need, you're going to know how much it's going to cost, and those are the things that we stress about day in and day out. So that's what I would say moving forward. I'm just going to echo what those guys said, 100%.
And my echo is if you're not capable, that would be me, of figuring that stuff out, you hire ethical people that know how to figure it out, that are not going to get you into trouble. Bobby, any closing remarks, please?
Sure. I think to underscore what everyone is saying, in order to maintain the value of your practice, in order to maintain the ability to come back to work, it comes back to having to have a patient base that trusts you and returns to you. So communication and safety has to be the paramount overlying issue that everybody stresses to them. In order to see patients, you also have to have team members to help you with that. So make sure that make sure you get a verbal commitment from each of your team members that they plan on returning. In order for you to build your schedule appropriately, you have to know who's going to be with you. So communication and connection are the two things that I go back to with both patients and with your team members.
Larry Jerrold, closing remarks, please. Okay, Larry, unmute. There you go. For an attorney, that's kind of an amazing thing.
Yeah.
His lips are moving and nothing's coming out.
Nothing's coming out?
Well, it is now. Good.
No, just look, this is probably my last pandemic. But for our younger listeners out there, this may not very well won't be the last rodeo. And I think everybody's got to develop certain skill sets that they're going to have to carry with them moving forward over the next 20, 30 years. This is an opportunity to develop these skill sets in terms of managing patients, managing staff, managing practice, and looking at our practices, not only as practices, but as businesses. And whether we have to hire people to do it or learn to do it ourselves, going forward, this is going to be the name of the game.
Gay Lowry, closing remarks, please.
I think that right now we have to make sure that we're communicating with clarity, starting first with our employees, and making sure that we script conversations so that the employees are relaying the information exactly as you intend it to be shared, because I think that's That's probably been one of the most confusing things with all the docs that I've talked to is the staff members are all on different pages about things. So take this time to begin to script how you want your messages delivered, both on the telephone, in email, in social media, and certainly face-to-face.
Bear in mind the definition of a great leader. This is Marcus Buckingham. Great leaders have a great vision. All of our visions have changed. Like it or not, what Larry Jerrold just said, talking with Martha Ann Keels, with her husband, Dennis Clemens, not arguably one of the most highly respected epidemiologists on earth. You need to understand that this can happen again. Maybe it won't be as severe. Maybe it will be as severe. It could be worse. It's not gloom and doom. It's what's your vision? What is your vision to get ready? Everybody's vision has changed. What is yours? And if you don't know what it is, it's time to figure that one out. Well, on behalf of all of us that are living and prevailing in the Black Swan event, we hope you found your time well spent. The recording of this will be available as soon as Phil Slonkosky has a chance to get that all settled up. You can look for it on iPedo. You can email me to get the link. It will be on YouTube. Our next meeting is going to be this Thursday at noon Eastern time. In addition to the usual suspects panelists, Rob Delarosa and Gay Lowry will be back. Stay safe.